This week, we will talk about urinary tract infections and how they are diagnosed clinically and in the clinical laboratory. Urinary tract infections are among the most common infections in man. In this lesson, we will discuss the clinical features of urinary tract infections, the patient population most susceptible to this infection, and their predisposing risk factors. Although identification of urine isolates is usually easy and simple, and please do review the identification of the common isolates listed in your objectives, the dilemma occurs in the interpretation of colony counts. Therefore, read the opening case study, the case in point. Consider the points I listed as you go through the lesson and your chapter readings. So the learning objectives for the lesson include be able to define the different terms associated with urinary tract infections. You should be able to describe the clinical features and the associated symptoms of various urinary tract infections. Differentiate the two routes of infection, the ascending route and the descending or hematogenous route. Explain the prevalence of urinary tract infection in certain age group and sex populations. Be able to describe the predisposing factors to this infection. List the common organisms associated with urinary tract infections and explain how they cause disease. Give the significance of the following colony counts when they are only between 1,000 to 10,000 colony-forming units per mil, when it is greater than 10,000 colony-forming units per mil, and when it is equal to or greater than 100,000 colony-forming units per mil. Be able to name the different methods of laboratory diagnosis by conventional methods and rapid detection and screening tests used. And lastly, evaluate the effectiveness of therapy as determined by bacteriologic response. Identify the most commonly isolated agents of urinary tract infections. As I mentioned, do review how to identify the following organisms: E. coli and other members of the Enterobacteriaceae, other enteric species, the non-fermenting gram-negative bacilli, especially Pseudomonas aeruginosa, gram-positive cocci, such as Staph aureus and coagulase-negative staph, and when they are significant when isolated in urine cultures. The enterococci. Although I may briefly talk about yeast, such as Candida albicans, mycobacteria, such as Mycobacterium tuberculosis, and parasites, especially Trichomonas vaginalis, as isolates that you may encounter in urine cultures. These are not included when it comes to testing. So again, just for a matter of completion, that there are other agents of urinary tract infections other than bacterial agents. Overall, the significance of the urine culture increases as the purity and quantity of growth increases. But before we begin to discuss the different types of infections encountered in the urinary tract, there are certain terms that need clarification. First is bacteriuria. It is the presence of microorganisms in a properly collected urine sample. Now, when bacteriuria is unaccompanied by clinical symptoms, but the colony count is greater than 10 to the 5th colony-forming units per mil, then this is referred to as asymptomatic bacteriuria. Pyuria is the presence of pus in the urine, while cystitis is inflammation of the urinary bladder. Acute pyelonephritis is a common bacterial infection of the renal pelvis and kidney, most often seen in young adult women. There are two additional terms need clarification. When a diagnosis of urinary tract infection is made and the patient receives treatment, as we will discuss later on in this lesson, there are occasions when treatment fails. When this occurs, it has to be determined if the infection is a relapse or a reinfection. A relapse occurs when the culture reveals the same organism, while during a reinfection, a different organism causes the treatment failure. So let's look at the case in point. This is about a 77-year-old surgical patient who developed dementia with concurrent fever and elevated peripheral white blood cell count. Blood and urine samples were taken for culture. The patient has been recently discharged to a long-term facility. Urine analysis showed positive leukocyte esterase and the presence of yeast and gram-negative rods. The culture grew greater than 100,000 colony-forming units per ml of urine, identified as Escherichia coli, Klebsiella pneumoniae, and other organisms. So here are some points to consider as we go through this lesson. What are the clinical findings or the presence or absence of symptoms in the patient? What is the age and what population group does the patient belong? What are the predisposing risk factors present, if any? What is the significance of the presence or absence of pyuria? What is the significant clinical colony count of a pure or predominant organism? And again, the characteristic features of the associated agents recovered from the urine culture. But first, let's start with the anatomy of the urinary tract. Urine is, what you see here is a figure that shows the anatomy of the urinary tract. Urine is produced by the kidneys and is excreted by way of the ureters, temporarily stored in the bladder until it is finally excreted through the urethra. Remember that when the urine is produced by the kidneys, it remains sterile until it is excreted, unless, of course, if the kidney is infected itself. Urine, however, becomes easily contaminated at the collection site, particularly with vaginal, skin, or fecal flora. Because urine itself is a good culture medium that allows a small number of organisms to multiply, proper urine sample collection, transport, and storage are critical in the interpretation of culture results. You will learn this in your clinical practicum, that you should not leave urine samples out at room temperature for a long period of time. Urinary tract infection is the presence of bacteria and may be localized to any portion of the urinary tract. The infection may be symptomatic, as I mentioned before, with symptoms, or asymptomatic. Bacteria may be present. UTIs may be divided into upper urinary tract infections that involve the kidneys and its pelvis. This type of infection is referred to as acute pyelonephritis or acute non-obstructive pyelonephritis. Symptoms of acute pyelonephritis include fever that usually exceeds 38 degrees centigrade, followed by chills and accompanied by flank pain. The infection may also be preceded or accompanied by dysuria in the severely ill, as well as vomiting, nausea, and diarrhea may also be present. In the absence of obstruction, this type of infection with proper treatment will resolve within a few days, leaving the kidneys intact. Nevertheless, this is a very painful event, and you know when you have a kidney infection. A true in the presence of obstruction or in patients with poor bladder control, the infection usually occurs and become persistent, leading to the chronic form of this infection, chronic pyelonephritis. So this is one of those infections that really calls for an immediate medical attention. Now, a true lower urinary tract infection involves the bladder, that is cystitis. This is also called what you call, in quotation, call to toilet, because this is when patients feel the urgency and frequency in urination, most often with pain and burning sensation. Again, if you have not had urinary tract infection, you will know when you have a urinary tract infection. This syndrome must be differentiated from urethritis, which is confined to the urethra, particularly in the male. Symptoms for both infections are similar with the exception of a mucoid or purulent discharge that accompanies urethritis. Another syndrome, prostatitis, especially in older men, that develops after placement of indwelling catheter, produces very similar symptoms as well. Most urinary tract infections are believed to arise from the ascending route via the urethral meatus, especially in women because of the inherent difference between the female and male anatomy. In the female, the organisms mostly come from the gut flora, reach the bladder via the urethra by one of these ways. One, by simple Brownian movement. Two, urethrovesical reflux, that is between the junction between the urethra and the bladder. In addition, some bacteria adhere to vaginal surfaces more easily. Infection occurs more easily in the female also because of the female urethra is shorter and its close proximity to the perirectal area. There's also an enhanced fecal contamination of the urethra in the female because of this anatomy, coupled with mild trauma to the female urethra, such as during sexual intercourse. Hence, the chance of infection is higher in the female. Now, the descending or hematogenous route, the arrow going down, is less common. It occurs during bacteremia or hematogenous spread of organisms from a remote site in which the organisms seed the kidneys. Staph aureus and Candida albicans bacteremia, for example, are common doing this. They may produce abscesses in the cortex leading to kidney infections. So when there is Staph aureus bacteremia or Candida albicans, it is not uncommon for these organisms to form abscesses in the kidneys. Occasionally, the organisms may originate from the kidney itself. That is, the organisms gain entrance into the bloodstream and are carried back to the kidneys to produce small abscesses throughout the organ. So if there is in the ascending route, the organisms infect the kidney and form abscesses in the kidney because the kidney is well supplied by blood vessels. As the blood goes through the kidneys, it then gets carried around into the bloodstream and then carried back, because the kidney is a filtering organ, carried back to the kidneys and produce more small abscesses throughout the organ. Now let's look at the epidemiology and risk factors associated with urinary tract infections. 10% of humans suffer from urinary tract infection at some time and point in their lifetime. Like I mentioned before, if you haven't had one yet, 10% of us will develop UTI at some point in time. The prevalence of infection depends on the age, sex, and sexual activity of the individual. So let's look at the male first. Approximately 1% of males acquire UTIs during infancy. However, the infection becomes uncommon thereafter until they reach their 60s or 70s. This is a time when enlargement of the prostate interferes with emptying of the bladder. At this age also, prostate obstruction and other diseases lead to instrumentation, generally catheterization. So you must remember that at any given time, regardless of age or sex, use of catheter or other forms of instrumentation is a risk factor for urinary tract infection. Now, in contrast, symptomatic bacteriuria in preschool age girls is up to 5%. And even with uneventful recovery, young girls who experience UTI at this age is at risk of recurrent infections during adult life. We will discuss more about this on the next slide. But in the female, the prevalence rises with age and sexual activity. If you notice in this graph, about the time that girls become sexually active, or at one time referred to as honeymoon cystitis, when women believed to develop UTI soon after they get married. Of course, this has changed, and this occurs, of course, you can move this graph. This is a fairly old graph that I have had for years, and this study had been done, as you may notice, and perhaps I speculate that this statistics was done back in the days when sexual activity really was not as prevalent at an early age as it is today. Lastly, the presence of obstructions such as stones increase the rate of UTI, as I mentioned earlier, in any given population. So instrumentation and the presence of obstructions such as stones or calculi both increase the rate and predispose people to urinary tract infections. So let's look at some predisposing factors to UTI. We already talked about age and sex. In the host defense, inherent defense mechanisms as part of a very important factor in the type of infection. And once this mechanism becomes compromised, the host becomes more susceptible to infection. So again, age and sex, we already know that the very young and the very old are more susceptible. We have already discussed the sex differences, such as the male versus female anatomy. In addition to these anatomical differences between males and females, the female urethra usually harbors a flora that consists of lactobacillus, diphtheroids, coagulase negative staph, but rarely gram-negative bacilli. However, studies have shown that in women who are about to develop UTI, enteric organisms have been found in their vaginal vestibules. Later, investigators also found that these women lack antibodies against these organisms. On the other hand, prostatic fluids contain antibacterial properties that may account for the increased resistance to UTI in the male population. Secondly, one of the most important host defenses against UTI is the act of voiding, which eliminates or flushes contaminated urine from the bladder, or at least maintain the numbers at low levels. This becomes a risk factor when the mechanism is impaired, such as in the presence of obstruction due to stones, or in individuals with impaired bladder control, such as those with spinal cord injury, and in pregnant women. Incomplete emptying of the bladder with each voiding encourages UTI because it does not clear or eliminate infected urine from the bladder. Retention of urine also interferes with the natural bactericidal properties of the bladder mucosa and the phagocytosis by leukocytes present in the area. So again, guess who does not empty their bladder as often as they should between male and the female? And we know why. We women, we're picky as far as the bathroom. Yeah, I can tell you stories between my daughter and my son, where my daughter will refuse. She would refuse to go to a rest area restroom and rather hold her urine in the bladder. And I have to tell her about, you need to go because you will come down with urinary tract infection. Next, frequent instrumentation, such as catheterization, promotes hospital-acquired UTI, especially in patients with chronic illnesses, such as diabetic patients who have inherent susceptibility to tissue infection and severe infections. Urethral catheter associated with UTIs are the most common hospital-acquired infections. These infections are inevitable and the rate is increased with the length of time the catheter is in place. Lastly, calculi, urinary tract obstruction, especially in the presence of stones or calculi, may occur anywhere from the kidney to the urethral meatus that may result in urinary tract obstruction. Stones that result from infection with urease-producing bacteria, such as Proteus, that favors the production of magnesium, ammonium, and phosphate, act as locus of infection. So let's look at the different types of organisms involved in UTIs. Even though the human gut flora consists of a wide variety of bacterial species, only a few are regularly encountered in UTIs. Among the gram-negative bacilli, E. coli accounts for 90% of acute infections. This may be attributed to its relative resistance to the inhibitory effects of the vaginal fluid, the presence of pili, that E. coli is motile, and certain strains are inherently more resistant to serum bactericidal effects. Lastly, certain strains isolated from upper urinary tract possess the K surface antigens not present in those isolated from the lower urinary tract, which means that they are more invasive. Most common hospital-acquired gram-negative bacillus is the non-fermenter Pseudomonas aeruginosa. Others that have been isolated from catheterized patients are the Klebsiella Enterobacter cerevisiae group, Klebsiella pneumoniae in particular, as well as the Proteus species, both Proteus mirabilis and Proteus vulgaris, and other enteric bacilli. Now, Proteus species are particularly virulent once established. As mentioned earlier, they produce large amount of urea. That's one thing that you need to remember with Proteus, is they produce urea that leads to the increase in pH and formation of ammonium hydroxide, both of which are directly toxic to renal cells. The increased pH also stimulates the formation of magnesium and ammonium phosphate, which are common urinary calculi. So review the biochemical features of these enterics. You should know at the minimum E. coli, Klebsiella, Enterobacter cerevisiae group, and how to differentiate them and identify Proteus species as well. Gram-positive cocci are infrequent cause of UTIs. It only accounts for about 8 to 10%. But among the gram-positive cocci, when involved, Enterococcus species and group D streptococci are the most common. So this is one thing that you have to remember, particularly in hospital-acquired urinary tract infections. When it is a gram-positive cocci, it is most likely Enterococci or group D streptococci. Staph aureus, when found repeatedly, is probably a manifestation of renal abscess, secondary to bacteremia. So this is a very significant isolate as well. UTIs due to coagulase negative staph, such as Staph epidermidis, may be encountered as a hospital-acquired infection, secondary to catheterization. So again, gram-positive cocci, when isolated from hospitalized patients, you can differentiate the enterococci and group D streptococci from a gram-positive staph by doing your calculase and doing your gram-positive cocci identification. Okay, while Staphylococcus saprophyticus causes as high as 20% of symptomatic UTIs in young sexually active women. Again, young sexually active women usually will be a community-acquired UTI in women. So this is something that you have to look at. Is the patient hospitalized when you isolate a gram-positive cocci, or is this a community-acquired infection? So you need to look at how the infection manifested in your patient population. With Staphylococcus saprophyticus, it has been speculated, as you have learned before, that the organisms may be sexually transmitted and are acquired from men with non-gonococcal urethritis. So as far as other agents, samples from patients may be suspected of infections due to Mycobacterium tuberculosis, and it should be processed appropriately. Other agents, which are infrequent isolates, are Mycoplasma and Chlamydia, and they have been associated with non-gonococcal urethritis, especially in women, and are considered sexually transmitted diseases rather than true UTIs. Similarly, as I mentioned before, Trichomonas vaginalis is usually visualized in urine samples, although it is a parasite that causes vaginitis rather than a true UTI. On the other hand, yeasts such as Candida albicans are found in patients who had antimicrobial therapy, those with diabetes, and have had indwelling catheters. In most cases, urine cultures are requested when patients present with signs and symptoms of UTI, although in some, infections are diagnosed through routine physical exam and patients are asymptomatic. So routine physical exam almost always will include urinalysis. And in some patients, this is when an asymptomatic bacteriuria may be detected. Urine cultures also are performed as a follow-up to determine if the prescribed therapy has been effective. Patients who have had indwelling catheters must be cultured when the catheters are removed or replaced. Now, one thing that you also will learn in your clinical practicum is that catheter tips are not accepted. They're not acceptable for culture because you can tell the tip would be colonized with your normal skin flora. But catheterized samples, it should be withdrawn from the catheter, not the catheter tip. Catheterized samples must be submitted. Similarly, urine cultures must be performed prior to instrumentation in patients with obstructive uropathy and stasis. And lastly, pregnant women are routinely screened for asymptomatic bacteriuria. Because the interpretation of the significance of growth in urine culture depends on the type of collection method, it is important that you know how the samples are collected. The most common collection method is what we call the clean catch midstream void. Here, cultures must be performed as soon as possible, and if refrigerated, should be set up within 2 hours of collection, because we know urine is a good culture medium. Growth in catheterized and aspirates carry more significance than midstream clean catch samples. So catheterized and suprapubic needle aspirates of bladder are also submitted for culture and carry more significance when organisms are isolated from the samples. Indwelling catheter tips, as previously mentioned, are not acceptable, as well as randomly collected samples from inadequately prepared patients and samples that have been left inadequately stored. So in the laboratory diagnosis of urine examination and urine cultures, we can start with direct microscopic examination that offers valuable information to the physician. A simple wet mount preparation will show the presence or absence of bacteria and inflammatory cells, that is white blood cells. One drop of uncentrifuged urine on the glass slide may be examined under oil immersion. 1 bacteria per oil immersion field in 5 fields will yield about greater than 10 to the 5th colony forming unit, while gram stain smear of the same uncentrifuged sample will produce a similar interpretation, while centrifuged urine sediment performed during urinalysis will show cellular elements, cast, and bacteria. So microscopic examination can provide a screening, if you may, whether there is bacteria or not. However, because of workflow and processing procedures, most laboratories really do not perform direct microscopic exam on urine samples, except for urinalysis. Quantitative cultures are done to provide an estimated colony count that allows differentiation between true bacteriuria and contamination. The calibrated loop is what we use. This is the most convenient and economical way to perform a semi-quantitative colony count, using a loop calibrated to inoculate 0.001 ml of urine, one colony that grows on a non-selective medium or differential medium represents 1,000 colony forming unit per ml. Other means to screen for bacteria include chemical and enzymatic tests like Grice tests for nitrate reduction and leukocyte esserase. These are parameters tested in routine urinalysis, and now urinalysis has been automated. So in most laboratories, what you'll find will be sending a urine sample collected in a sterile container, sent first to microbiology laboratory for the microlab to set up the quantitative urine culture, and then the same urine sample is sent to the urinalysis section of the laboratory to do the urinalysis. Here's a direct gram-stain smear showing both gram-positive cocci and gram-negative rods. Be sure that you're able to correlate these gram-stain findings on the primary culture media, which routinely will include blood agar plate for gram-positive and gram-negative bacteria, MacConkey for your gram-negative, and a gram-positive selected medium such as phenyl alcohol or CNA, glycinylidesic agar, or Columbia agar as a selected gram-positive media may also be included. So review the different types of selective agar media. So in this example, what should you expect to find on the blood agar plate? Right, so you have gram-negative rods and gram-positive cocci. So in your blood agar, you should find or look for two types of colonies, a gram-positive and a gram-negative colony. Then you will semi-quantitate the number of colony-forming units per type of morphology. The next thing that you want to do is check your MacConkey. If the urine culture grew E. coli, what would it look like on MacConkey? You should find lactose fermenting dark pink colonies on MacConkey. If Enterococcus faecalis was isolated or was found in the culture, what would it look like and where would it grow? Enterococci would be present in your blood agar plate. Recognize the typical colony morphology of Enterococci, and it should also grow on your Columbia agar. This is how you should correlate the gram-stain findings with the culture results. You count how many different morphology are you seeing in your gram-stain, and you should check your culture plates and also count how many types and different types of colony morphology are growing on your culture. Now let's go over how to determine the clinical significance of the colony of the urine colony count using this chart. As per definition, significant bacteriuria is a colony count of greater than or equal to 100,000 colony forming units per ml of a single species from a ClinCat sample. From a ClinCat sample, it has an 80% probability of significant bacteriuria, while from a catheterized sample, it shows a 95% probability. So it should make sense that the more sterile the sample is, the more significant the colony count would be. Colony count between 10,000 but less than 100,000 of a single species it is a pure culture. From a catheterized sample are indicative in the following. Even though in the ClinCat, it is only 5% significance or true probability of true infection, and 50% probability from a catheterized sample. Some of the reasons that you might find this number of colony count and still indicative is in patients in antimicrobial therapy. So it makes sense that the colony count, even though there's an infection, will be a lot lower. In excessively hydrated patients, so when patients are receiving IV intravenous fluid, then they are excessively hydrated. So again, the organism's count will be diluted, if you may. Very acid urine. The organisms usually will not survive in acidic pH. And usually infections caused by non-enterics. That means non-lactose fermenting or other types of organisms don't produce a high colony count unlike the enterics. Okay, so a colony count of 1,000 colony forming unit pure culture are indicative in samples collected by suprapubic aspiration. So 1,000 colony count per mil, it is one colony if you're using a 0.001 mil calibrated loop. So again, the more sterile your sample, the more significant whatever it is growing on your culture plate. What about if there are more than one organism? Just like our direct gram stain smear. Isolation of two organisms, both in quantities of greater than 100,000 colony forming units per mil, from a catheterized sample is indicative of true infection. Both in quantities of greater than 10,000, there are two organisms of greater than 10,000 is indicative in suprapubic aspirates. From patients such as newborns, paraplegics, patients with indwelling catheters, low counts, 1,000 to 10,000 are significant in symptomatic young females. Again, saprophyticus, Staphylococcus saprophyticus, they usually do not generate high colony counts. So again, when you isolate a gram-positive cocci, you look at the age of the patient, okay, and you identify it as a coagulase negative staph, you need to proceed to identifying it as saprophyticus, even if the colony count is low. Now, growth of two or more growth of more than two organisms indicates either contamination during collection or delay in inoculation. So this is perhaps one of those samples where you need to look at the time stamped when the sample is collected, especially when the growth on the culture includes more than two organisms, because this could have been a urine sample that sat out in the nurse's station for a long time, and there is not a true UTI in this particular patient. Just briefly, I want to spend just a couple of minutes in talking about the treatment of urinary tract infections, especially to evaluate the efficacy of the therapy. Evaluation of effectiveness of therapy may be determined by 1, the clinical response, and that is disappearance of clinical symptoms. 2, bacteriologic response, when repeat cultures yield no growth within 24 or 48 hours. In some patients, relapse may occur, that is, the infection returns with the same organism. This is usually due to patient non-compliance in completing the prescribed medication, particularly non-hospitalized patients. It is not unusual that patients stop taking or finishing the therapy as soon as symptoms disappear. Reinfection, however, is more common where there is a new organism causing the disease. The new organism, usually one that originates from the bowel flora, causing the treatment failure. But sometimes relapse occurs due to resistant strain or a mutant, where organisms change their susceptibility patterns. This is not uncommon, particularly among the Pseudomonads. So although you have already identified the organism once before, susceptibility testing is always done in urinary tract isolates. So points to remember about urinary tract infections. Clinical findings, remember the clinical findings or presence or absence of symptoms. You have to be aware of the age and the population group, the sex, is it a community acquired or is it a hospitalized patient? Determine the predisposing risk factors present. In your analysis, you should be able to go find the presence or absence of pyuria. The presence of pyuria is indicative of a true infection. What is the significant colony count between a pure culture, or what is the predominant organism? And again, be able to identify, describe the characteristic features of the associated agents. This is the end of this presentation.